Okay, let's get started on part 7. And this is going to be part 7 of 7. All good things have to end someday. And this is our last talk on hepatic masses. I think we've really looked at many cases. We've looked at challenges in the differential diagnosis. And I want to give you a few more challenges and a few more points. And then what I'll do is I'm going to end up looking at the future. And perhaps the future might be, will AI ever help us? Now, I mentioned before, the last slide from the last talk, there are other primary hepatic tumors. They're rare. Angiosarcoma of the liver, primary hepatic sarcomas, or primary neuroendocrine tumors. Here's a mass in the liver, and there are multiple masses. If you look at it, it looks, okay, hepatoma maybe, metastasis, but if you look carefully at the edges, there's low density. And if you look at that even more carefully, those measure fat. Now, you can get benign liver lesions. Myelolipomas occur in the patient's liver, and we see that with tuberous sclerosis. You see lesions in the liver as well as lesions in the kidney. But this is a dominant mass with fat. There's some vascularity. Again, here measurements are in the -40s. What could this be? It looks like a large aggressive tumor with fat. Now, it is true hepatomas occasionally can have fat. We talk about adrenal cortical carcinomas can have fat. Renal cell carcinomas can have fat. Hepatomas can occasionally, though really rare, have fat within them. Here we accentuate it a bit more. So now we're looking and saying large mass with fat. What kind of tumor is this? It doesn't look benign. It looks large. It looks aggressive. And this was a primary liposarcoma of the liver, a very rare tumor indeed. Now, a tumor we talk about in the spleen and in the liver is angiosarcoma. It's very, very uncommon. I did see a few cases this past year. When we talk about risk factors, environmental, iatrogenic, things like thorium dioxide, vinyl chloride, arsenic, and radiation are things we tend to think about, but that's more common with splenic angiosarcomas, not so much hepatic. So it's kind of rare. Growth pathology and imaging findings of hepatic angiosarc can show 4 different patterns: multiple nodules, a dominant mass, a combination of large masses and small masses, and occasionally an infiltrating tumor, which basically means it can look many different ways, and the tumor is so rare, hard to make the call. Now, when you do see angiosarcomas, they're aggressive tumors. You could think about hepatoma, you can think about metastasis. One thing that can be very helpful is angiosarcomas are very, very vascular. If they have mets to bone, the mets are going to be very vascular. In the old days, we talk about Thoratrast, which was used as a contrast agent in the 30s and 40s, and patients had high doses of radiation and got splenic angiosarcomas and liver angiosarcomas. And angiosarcomas, if it was used in soft tissue, everywhere they got sarcomas, but those patients have all passed away by now. Here's an example: big, really infiltrating liver mass, very vascular. Again, you might think about hepatoma, large mass, irregular texture, lots of neovascularity. Hepatoma is a good thought. Could this be melanoma? Melanoma can be vascular. They can provide large masses, but usually it's more likely multiple. This is not the look of cholangiocarcinoma, and we know this is malignant. When you see such irregular vascularity, look at it on the coronal, particularly the coronal MIP. You should at least make the point prior to biopsy, could this be an angiosarcoma? Very impressive vascularity. And here's how the lesion looks when it's on venous phase. When it washes out, it's really an infiltrating tumor with scarring and infiltration. The liver just looks markedly irregular. It almost looks like cirrhosis or a pattern of severe parenchymal liver disease, but the rest of the liver, like the posterior right lobe, looks okay. So you got to say this is an infiltrating process. Again, coronal views showing the infiltration, and this was a primary angiosarcoma of the liver, a really interesting case. Another patient has pleural effusions, The patient looks like they've bled. There's a mass in the liver. It's vascular, but not as aggressive as the prior case, but now you see the mass pretty well. If you have all of the images, you'll notice that the patient has had a right nephrectomy. And this patient was in their 20s. Right nephrectomy was a Wilms tumor when the patient was younger. The patient had radiation therapy. And now in the radiation port, the patient has a mass in the liver. Angiosarcomas can occur as a result of radiation therapy. And typically it'll occur 20 to 30 years later. It's uncommon, and the good news these days is we don't use the same radiation dose we used in the past, so radiation-induced sarcomas are indeed going to be very rare. But here was a nice case with an angiosarcoma with spontaneous bleeding in a patient who had radiation for Wilms tumor. Now, just to make the point about bleeding, remember we made the differential before. Hepatoma, hepatic adenoma are the common things. And we did mention that metastasis or primary tumors like angiosarcoma can present with spontaneous bleed. Now, one thing I'll mention, although this talk for the most part was on hepatic masses, was hepatic abscesses. And the reason I mention it is many times abscesses are obvious. A patient with a new liver lesion and diverticulitis, a patient with a new liver lesion and appendicitis, a patient with a new liver lesion after recent surgery. That kind of makes it easy. Or the clinical symptoms, the patient has traveled, maybe the patient has an amoebic abscess or hydatid disease. Those are all possibilities. But the thing to remember is abscesses are very tricky, and it's very easy for abscesses, if you don't have a good history, to be confused with malignancies, because abscesses have many appearances. Here's a large stellate-looking lesion. It's hypovascular. It's cystic. If I told you this was a hepatoma that was necrotic, or a cholangiocarcinoma, or metastasis, you would say it's a possibility. It has a pseudocapsule. It's a solitary, large mass, but it's solitary. Pyogenic abscesses, hematogenous spread from the GI tract, ascending cholangitis, E. coli is the most common agent, fever, right-sided abdominal pain, even weight loss. Remember, FUO could be the earliest sign of malignancy. Same thing with weight loss. So abscess and tumor can be very similar, and it also has elevated liver functions. Another case, infiltration left lobe of liver, maybe a tiny air bubble there. You can see it on the coronal view. Could this be lymphoma? Could this be, I showed you a funny case of hepatic adenoma. Could this be malignant infiltration? When you get venous phase, look how large this mass is, and you have to be thinking about tumor. This was biopsied, it was an abscess. And so abscesses are great mimickers of tumors. Sometimes the history helps you, sometimes the physical exam helps you, but sometimes it's simply the biopsy. Another example, multiple hepatic lesions. Again, could this be metastatic disease? The patient has a duodenal diverticulum. The patient has no other findings that are seen on these images. But look at the venous phase. It looks like a pseudocapsule, looks like a cluster of lesions. One of the signs of a liver abscess is a cluster or clover sign. This is pretty close to a clover sign. You got to think about an abscess. Here it is on the cinematic rendering. A really nice example. But again, hard to exclude metastatic disease. And this was a liver abscess due to E. coli infection. This was a patient who ate a chicken bone, and in fact there was a retained chicken bone in the appendix. This patient presented with fever and abdominal pain. This was a large abscess in the liver. Again, looks very similar to some of the tumors I showed you. And yes, there's the patient's chicken bone, or it could be a big bone from a fish maybe, like a carp, but it's a foreign body there. It could be a needle or something else. But it's in the appendix. The patient had appendicitis and had multiple hepatic abscesses. Or this case, the patient had traveled to Mexico. There's a lesion in the right lobe of the liver. It's cystic. This patient was young, and because of the history of fever, we thought about a possible abscess. Again, could this be a necrotic tumor? The answer is yes. This was biopsied. You can see the thickened rim. This was an amoebic abscess. Amoebic abscesses are classically solitary lesions, but not always. Most common right lobe of liver, and have this rim-like enhancement pattern. That's really good for amoebic abscess. Very nicely shown here on the coronal view as well. Amoebic liver abscess. Another case, multiple low-density lesions, patient with foreign travel to Africa. Again, amoebic abscess was a consideration. There are multiple lesions. Other abscesses. Patient was young, so tumor was felt to be unlikely. This was biopsied, and to everyone's surprise, this lesion, which we assume was going to be some unusual abscess, was hydatid disease. Now, with hydatid disease, you think about multiple cysts. You also think about cysts with calcification. This was probably the most atypical hydatid cyst case I've ever actually seen. Hydatid cysts are more like this case, and I showed you a couple images like this probably 5 talks ago when I spoke about the differential diagnosis of cystic hepatic lesions. But here's a large cystic lesion with multiple daughter cysts. That's the classic appearance of hydatid disease. This patient had a history of being a veterinarian. He was from Ethiopia. Common places for hydatid disease, and that classic appearance on CT makes the diagnosis indeed very simple. Now, in the patient who's post-op with new liver lesions, particularly like in this case, when it has air bubbles, fever, it's really easy. It's an abscess in this patient post-Whipple's. You can have abscesses and infarcts together. You can have solitary abscesses or multifocal abscesses, as you can see in this case, and the lesions actually look like infarcts. Sometimes what happens is you get an infarct, and the infarct then develops into an abscess, and not uncommon complication of Whipple's procedure. Now, one challenge we do have occasionally, patients post-Whipple's will get an abscess 3 to 4 weeks post-surgery, and then when you're scanning the patient, because it's often the patient's not presenting with fever, but for their post-op study, and you say, oh my goodness, the patient has a MET. So you need to be careful. Patients who are a month to 2 post-Whipple's procedure, before you call recurrence, make sure you think about the possibility of an abscess. Another patient, right upper quadrant pain, infiltrating process, cystic, low density. Could this be a big necrotic tumor? Possible. Could this be a big abscess? Possible. This needs to be biopsied. I don't know what this is. Could it be arising from the diaphragm pushing on the liver? Less likely, but a possibility. And this was resected because the biopsies weren't helpful. This was an inflammatory pseudotumor of the liver. Inflammatory pseudotumors are unusual cases. They're impossible to diagnose till you get removal and pathology. Okay, uncommon benign lesion, but it looks like malignancy, be it hepatoma or cholangiocarcinoma. Again, an unusual lesion, but one that is usually diagnosed by the pathologist, not by the radiologist. So we've covered a lot of things, and one thing you recognize is there's so many different lesions. Can we do better in being specific? We also want to figure out, can we do better in picking up tiny lesions? But what about classification? Can AI help? Is there a role for AI in the evaluation of hepatic masses? What are the potential uses of AI in the evaluation of the liver? And where is AI today in the evaluation of the liver? And again, liver cancer is a global concern. In this article by Horry, makes the point that AI is recognized as a promising tool, perhaps to help us pick up hepatoma at an earlier stage. Again, early detection, looking at parenchymal changes in the liver, tumor characterization, segmentation, and then with radiomics. The role of AI is growing in looking at the liver, detection, classification, and management. are all the things. Also, generative AI, including ChatGPT, shows promise for potential applications in medical imaging, looking at charts, looking at history, perhaps looking and finding patients who are at risk for developing hepatoma. Now, it's true liver imaging with AI is not at the level of breast imaging or lung cancer, perhaps. It probably isn't where pancreas is. And again, the challenge is you need lots of cases. We don't have really good protocols often on cases, so it is challenging being able to train the computer, but it's not impossible. We also look at radiomics to be able to look at features of lesions, and with radiomics, with pancreas, we can predict benign versus malignant, whether it's neuroendocrine. If it's neuroendocrine, what's the grade of the tumor? We can predict what chemotherapy will work or not work. There's lots of things we could think about, and perhaps the same thing can be done in looking at the liver. Radiomics specifically enables non-invasive profiling of tumors through routine radiologic images. And again, this possibility of training, and again, our focus personally has been with pancreatic cancer, but with hepatic tumors, particularly hepatoma, this may become very, very important. This idea of being able to use the information from AI with lab information, with sequencing, can we put all this together to aid in forecasting the future of hepatic tumors? Again, there is a challenge. It's hard enough getting pancreas. Hepatomas are less frequent. We would need to get lots of different tumors, benign and malignant. But we always know there are problems. But hepatoma is a worldwide problem, so perhaps, and it's very big in China, so perhaps everybody working together can help us. And this article by Mian, Radiomics for Treatment Planning in Liver Cancers, really looks at that point. Again, detection as well as predicting, looking at can we use radiomics signatures for predicting how chemotherapy will work. And it does seem that that is really helping out. And again, can we predict who should get TACE versus chemotherapy versus surgery? All of these things are challenges, but as we finish this talk, I want you to think about where we're going. And this will need people working together because we need standardization of protocols and we need large volumes of cases if we're going to make this work. Routine application of radiomics and oncologic liver treatment planning depends on outcomes of prospective studies and regulatory approval. Multi-institutional collaborative networks are required to harness data for generalizable models. We anticipate routine use within the next decade if these challenges are addressed. So it may not be something happening next week or next year, but we need to make it happen. Maybe not the next decade, maybe less than that. So summary statements. We've had 7 lectures in the 20 to 25 minute range. We've covered a lot because I wanted to give you lots of examples and look at the challenges. I wanted to show you not just on the detection side of things, but on creating a differential diagnosis that really allows us to be very specific and not to give a laundry list of 20 possibilities. We need to understand how we can do better. We need to understand the importance of proper protocols, the role of multi-phase imaging, and the potential value of post-processing, particularly things like cinematic rendering. We need to understand the signature appearance of various tumors. We need to understand the importance of clinical history, perhaps the role of ChatGPT, and looking long-term, the role of AI in the evaluation of liver disease. So with that, I thank you for your attention. If you have any questions, let us know. If you want to see lots of cases, go to CTisus website, the teaching file. There are lots of cases to look at. And with that, have a great day. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.